Assalamu alaikum. Now I would like to discuss about some important topics regarding respiratory system. Start with this bronchopulmonary dysplasia. What happens in bronchopulmonary dysplasia, also known as chronic chronic lung disease of the neonate, old bronchopulmonary dysplasia and new bronchopulmonary dysplasia. Old is prolonged mechanical ventilation and hyperoxia. Prolonged mechanical ventilation and hyperoxia. There is chronic inflammation, fibrosis, and interstitial edema. And new bronchopulmonary dysplasia is prematurity. That means arrest of the arrest of the pulmonary development, alveolar hypoplasia, and decreased septation. How can you diagnose a case with bronchopulmonary dysplasia after seeing the stem? If you find a baby getting supplemental oxygen more than 28 days, if a baby needs supplemental oxygen, if a neonate needs supplemental oxygen more than 28 days, diagnosis done. This is bronchopulmonary dysplasia, and there may be respiratory distress present. And if you do the X-rays, there is diffuse haziness and decreased lung volume. These two words is a very high yield. That diffuse ha haziness and decreased lung volume. There may be hyperinflammation. There may be cystic or fibrotic change in case of old bronchopulmonary dysplasia. How should we treat? We should optimize nutrition and win respiratory support if possible. Another bronchopulmonary dysplasia in here, there is a topic regarding bronchopulmonary dysplasia. In bronchopulmonary dysplasia, there is premature arrest of the pulmonary development, premature arrest of the pulmonary development. There is premature arrest of the pulmonary development. There is alveolar hypoplasia with decreased septation. There is impaired vasculogenesis. There is impaired vasculogenesis. Clinical diagnosis is premature infant with continuous supplemental. This word is always the same. And a chest X-ray, diffuse hazy infiltrate, low to normal lung volume, and in severe cases there is fibrotic changes and hyperinflation. Treatment is supportive care, oxygen, nutrition, and fluid restriction on diuretics. And the must know things, the complications. There may be pulmonary artery hypertension, there may be cardiovascular disease, there may be recurrent respiratory infection. Pulmonary artery hypertension, cardiovascular disease, and recurrent respiratory infection. And there are some definitions where you said oxygen required at 36 weeks of postmenstrual age. Oxygen requirement at 36 weeks postmenstrual age, that is gestational and chronological age. So if a baby getting supplemental oxygen for more than 28 days and you do chest x-ray and there is diffuse Haze infiltrate low to normal lung volume. There may be fibrocystic changes and hyperinflation. Then the diagnosis is done. Bronchopulmonary dysplasia. There may be pulmonary artery hypertension. There may be systemic hypertension. There may be recurrent respiratory infections. Okay, next thing, that is aspiration. There may be aspiration pneumonia. Okay, first of all, aspiration pneumonia. The predisposing condition of aspiration pneumonia, there may be altered consciousness. There may be altered consciousness, impaired cough reflex, glottic closure like dementia or drug intoxication. So, altered consciousness, impairing cough reflex or glottic closure, dysphagia due to neurological defect like stroke, neurodegenerative disease, upper GIT disorder like GERD, nasogastric and endotracheal tubes like mechanical compromise of aspiration defenses, protracted vomiting, and large volume tube feedings in recumbent position. These things can cause aspiration pneumonia. Also, large volume tube feeding in recumbent position, altered consciousness, which impaired cough reflex and dysphagia due to neurologic deficit, upper GIT disorder, GRD, mechanical compromise of aspiration devices, nasogastric and endotracheal tubes. Aspiration pneumonia typically develops over the course of days and causes low-grade fever. Aspiration pneumonia, a few days to weeks. It onset is few days to weeks. There may be fever, dyspnea, and productive cough. There may be fever, dyspnea, and productive foul-smelling cough. It may be complicated with necrosis and abscess formation. And in here, patient with impaired consciousness, advanced dementia like Alzheimer's, and other neurological condition like stroke, when these may impair swallowing and cough reflex. Broad spectrum antibiotic can be given, ceftriaxone plus azithromycin, that target the community acquired, and there may be other antibiotic can be given. Broad spectrum antibiotic with good anaerobic coverage like clindamycin can be given, but usually ceftriaxone plus azithromycin is usually preferred. in aspiration in aspiration there may be pneumonitis versus pneumonia. That means chemical pneumonitis versus pneumonia. Chemical pneumonitis versus pneumonia. In chemical pneumonitis, Okay, these box like difference between these two, l- like aspiration pneumonia versus chemical pneumonitis. So in chemical aspiration, maybe pneumonitis versus pneumonia. So chemical pneumonitis, inhalation of the gastric acid that leads to direct chemical injury of the bronchial and alveolar epithelial cell. This is chemical pneumonitis, and inhalation of the large inoculate of the oropharyngeal or gastric microbes overwhelms host pulmonary defenses. The onset is sudden within minutes. Aspiration happens sudden within minutes. And in aspiration pneumonia, there is indolent a few days to weeks. Manifestation: abrupt onset dyspnea, cough, abrupt onset dyspnea, cough, hypoxemia, low-grade fever, diffuse crackles or wheezes, infiltrate in dependent portion of the lung, infiltrate in dependent portion of the lung. This is chemical pneumonitis. In aspiration pneumonia, there is fever, cough with putrid sputum, and inoculate in dependent portion of the lung. Management is supportive care and oropharyngeal suction if event is witnessed. And in aspiration pneumonia, antibiotic, like I have already told you, that ceftriaxone plus azithromycin that target the community acquired pneumonia. Another box regarding chemical pneumonitis: it may be due to gastric reflux, it may be due to increase in intra-abdominal pressure. This one is very high due to increase in intra-abdominal pressure. There will be altered consciousness, there decrease delayed gastric emptying, endotracheal intubation, and nasogastric tube. It usually happens within hours of the aspiring agent. There is acute onset dyspnea, but if occurs in a few days to weeks, that is aspiration pneumonia. If occurs within an hours, that is aspiration pneumonitis, not aspiration pneumonia. Aspiration pneumonitis or chemical pneumonitis. Acute onset dyspnea, low grade fever, hypoxemia, diffuse crackles in the lung. Supportive care and no antibiotic is needed. So pneumonia versus pneumonitis. Pathophysiology: pneumonia usually in the lung parenchymal infection, and pneumonitis is lung parenchymal inflammation. So pneumonia is a lung parenchymal infection, pneumonitis is lung parenchymal inflammation. Aspiration of the upper airway or stomach microbes, and in pneumonitis, aspiration of the gastric acid with direct tissue injury. Aspiration of the gastric acid with direct tissue injury. Pneumonia present days after aspiring agent, then with fever, cough, and high sputum. Chest X-ray infiltrate independent lung segment, classically in the right lower lung. Can progress to abscess. Pneumonia can progress to abscess, usually right lower lung. Clindamycin or beta-lactam antibiotic, beta-lactam inhibitor can be given. But in pneumonitis, aspiration of the gastric acid with direct tissue injury present within hours. There is low-grade fever, decrease oxygen or respiratory distress. Chest infiltrate one or both lobes and resolves without antibiotic. This is important. It resolves without antibiotic. The symptoms usually resolves rapidly 24 to 48 hours with supportive management, and no antibiotic is needed in pneumonitis. No antibiotic is needed in pneumonitis. Then obstructive lung disease. In obstructive lung disease or restrictive lung disease, obstructive lung disease, FEV1 decreased, FEV1 by FVC decreased, FEV1 by FVC decreased, FVC normal to decreased. In a restrictive lung disease, FEV1 decreased, FEV1 by FVC normal or increased, and FVC decreased. In pulmonary function test, low FEV1 by in pulmonary function test, low FEV1 by FVC ratio, obstructive pattern, normal or high FEV1 by FVC ratio, restrictive pattern. Then we will do DLCO. If DLCO is decreased, that is COPD. If DLCO normal or increased, it is asthma. And in restrictive, normal or high FEV1 by FVC, then we will do DLCO normal in chest wall weakness, and DLCO decrease in interstitial lung disease and granulomatous disease. Interstitial lung disease and granulomatous disease. Okay, differential diagnosis based on DLCO in obstructive pattern. That means low FEV1 by FBC ratio, low DLC is emphysema, normal DLCO chronic bronchitis, and asthma, and increased DLCO is also asthma. In restrictive pattern, that means normal or increased FEV1 by FBC ratio, low DLCO, is interstitial lung disease, sarcoidosis, heart failure, and asbestosis. And normal DLCO is musculoskeletal deformity and neuromuscular disease, and more. And increased DLCO is morbid obesity. And normal spirometry. In normal spirometry, low DLC is anemia, pulmonary embolism, and pulmonary hypertension. And increased DLCO is pulmonary hemorrhage and polycythemia. and polycythemia. Then the next topic is amniotic fluid embolism. In amniotic fluid embolism, uh, there may be advanced maternal age, gravita more than 5. There may be advanced maternal age, gravita more than 5, live birth, cesarean or instrumental delivery, placenta previa or abruption, and preeclampsia. Clinical feature is shock. There may be a cardiogenic shock. There may be shock, cardiogenic, hypoxemic, respiratory failure. There may be DIC, coma, or seizures. Respiratory or hemodynamic support and transfusion. Respiratory hemodynamic support and transfusion. Amniotic fluid embolism can enter into the maternal circuit through endocervical veins, placental insertion site, and areas of uterine trauma, cesarean incision site. Amniotic fluid can enter through cesarean incision site. Is diagnosed clinically after excluding sudden postpartum cardiorespiratory failure like eclampsia, peripartum cardiomyopathy, pulmonary embolism. Treatment mainly supportive to correct hypoxemia, oxygen intubation, mechanical ventilation, and in hypoxemia, vasopressin can be given. Early recognition with respiratory and hemodynamic support. So in amniotic fluid, as amniotic fluid embolism syndrome. In amniotic fluid embolism syndrome, there may be these three things can happen. So hypoxemic respiratory failure, obstructive shock, there may be obstructive shock, there may be obstructive shock due to pulmonary edema, and DIC can happen. DIC can happen. These are the most important high-yield feature of amniotic fluid embolism. Then then the very high-yield topic, obstructive sleep apnea. Pediatric obstructive sleep apnea, stop bang, obesity hypoventilation syndrome. These are a bunch of things we have to remember. And another thing, a baby comes with, suppose a baby comes with the features of um, a baby comes with the features of ADHD. In those baby, you have to look for this apnea, that pediatric obstructive sleep apnea, pediatric obstructive sleep apnea. These are very high health thing you have to remember. So pediatric obstructive sleep apnea. In pediatric obstructive sleep apnea, it the reason why is adenotonsillar hypertrophy. Obstructive sleep apnea is adenotonsillar hypertrophy. So you have to rule out this by X-ray nasopharynx lateral view. By doing, you can get this adenotonsillar hypertrophy, and you should do adenoidectomy and tonsillectomy in such case. But what are the symptoms? Night symptoms like loud snoring, pauses in breathing, gasping, aneurysm, parasomnia, sleepwalking, sleep terror, day symptom inappropriate naps, falling asleep during school, irritability, inattention, learning problem, behavioral problem, mouth breathing, nasal speech. Poor growth, complication is poor growth, failure to thrive, poor school performance, and cardiopulmonary like hypertension and structural heart disease, tonsillectomy, and adenoidectomy. In obstructive sleep apnea, that means in case of adult person, there is a relaxation of the pharyngeal muscle leading to closure of the airway, loud snoring with period of apnea, daytime somnolence, and obstructive daytime somnolence, morning headache, affective and cognitive problem, aneurysm, polycythemia. Secondly, systemic hypertension. There may be pulmonary hypertension and right heart failure. In obesity hypoventilation syndrome, if BMI is more than 32 milligram, 32 kg per meter square is the strongest risk factor of obesity hypoventilation syndrome. The sequelae of obesity hypoventilation syndrome is erectile dysfunction. Erectile dysfunction, abnormal sleep cycle may lower testosterone, and arterial hypertension may be prompt. An initial OSA is a common secondary hypertension and production of the catecholamine during apneic episodes. The hypertension is often resistant to medications. Obstructive sleep apnea is frequently implicated in drowsy driving, motor vehicle collision. Nocturnal polysomnography should be ordered to confirm the diagnosis. Untreated obstructive sleep apnea persists, developed overlap with depression, low mood, fatigue, sleep disturbance. Untreated obstructive sleep apnea, low mood, fatigue, sleep disturbance, impaired concentration, and primary depressive disorder. Major depressive disorder should not be diagnosed in this patient. Patient with obesity, hyperventilation syndrome, and obstructive sleep apnea can cause chronic hypoxia and hypercapnia. In an effort to maintain normal pH, the kidney increase bicarbonate retention and decrease chloride reabsorption. Increase bicarbonate retention and decrease chloride reabsorption to create and compensatory metabolic alkalosis. Stop bank. Stop bank survey 1.0 to 2 means low risk, 3 to 4, more than 5 is high risk. Stop bank snoring, obstructive sleep apnea, snoring, excessive daytime tiredness. Observed apnea or choking or gasping. High blood pressure, BMI more than 35, age more than 50, neck size in case of men more than 17, women more than 16, and male gender. So may stop bang, snoring, excessive daytime tiredness, obesity, BMI more than 35, pressure, high blood pressure, BMI more than 35 kg, age more than 50, next size men in case of 17 and women in case of 16, and male gender. In obesity hyperventilation syndrome, if BMI obesity hyperventilation syndrome BMI more than 30 kg per meter square, avoid daytime hypercapnia PaCO2 is more than 45 millimeter, and no alternate cause of hypoventilation. ABG on room air is hypercapnia normal A gradient. Workup is ABG in room air. There may be hypercapnia, no intrinsic pulmonary disease. On chest X-ray, restrictive pattern of pulmonary function test. Polysomnography, normal TSH. Nocturnal positive pressure ventilation are the first line therapy, weight loss and bariatric in selected cases, avoidance of sedative medication, and the last sort of treatment is last resort is respiratory stimulant. Defended daytime hypercapnia, PaCO2 more than 45 in obese, BMI 30, more often 40 without another explanation of the hypercapnia. So daytime hypercapnia in an obese patient without another explanation for the hypercapnia. Most patients have coexisting obstructive sleep apnea with frequent apneic events and daytime hypersomnolence. Other features of obesity hypoventilation syndrome include dyspnea, polycythemia, respiratory acidosis, compensatory metabolic alkalosis, pulmonary hypertension, and core-pulmonary arterial blood gas will show hypercapnia, hypoxemia, and respiratory acidosis as a result of altered lung mechanics due to obesity and hypoventilation. And that's all about the some topics regarding respiratory. Hope you enjoy.